So our next speaker is Dr. Brian Kavanagh. He attended medical school at Tulane University in New Orleans and completed his residency training in radiation oncology at Duke University, where he was an American Cancer Society Fellow. He's currently a professor of radiation oncology at University of Colorado. He's involved in numerous clinical and translational research projects related to stereotactic body radiosurgery and has published extensively on the topic. Dr. Kavanagh.
Thanks very much. I'm in this folder. Yeah, thanks. So I'm getting set up. First of all, I'd like to thank you guys for the invitation. It's been a very wonderful visit so far. The hospitality has been terrific. We had a wonderful dinner last night with some of you, and I got to meet Mr. Tatar, and we talked about a lot of things, sparkling conversation, politics on the board there. I think we solved a lot of problems. Unfortunately, we didn't record the conversation. Next time we'll put the tape recorder on because we would be in great economic shape if we had remembered to do all that. So, okay. Well, I'll try to go through a talk structured more or less in this way. We'll just go over this notion of oligometastases and maybe talk about that as an example of a theory and one of several which supports the idea, the somewhat crazy idea of using a localized therapy for some patients with metastatic disease. Talk a little bit more specifically about the tumor ablative forms of radiotherapy. We'll begin with the cranial example, which is where it all starts, and then we'll extend that to the extracranial setting, if you will, in this concept we now call stereotactic body radiation therapy. I'll develop that topic just a little bit more and give some more examples about SBRT for lung, spine, and liver metastases, and then I'll wind up with a crazy term that for a little while now, some colleagues and I have been calling Darwinian oncology, and we'll sort of say what is up with that anyway. Let's consider this word that's part of the title of this symposium. It has an unusual sort of mixed Latin and Greek etymology, if you will. The practical definition, as was nicely stated by Dr. Einstein, is that it's a condition whereby we recognize that a patient may have gross tumor spread away from the primary site of cancer, but still a low enough burden for oncologists to want to remain very aggressive. Where exactly you draw that line is sometimes a matter of style and sometimes a matter of institutional preference. But the notion is that it's simply not right to quite give up on this person, and we still want to be somewhat aggressive, and there's reason to hope that we can extend a person's survival and certainly maybe even maintain a high level of quality of life in that during that time. This word was coined in about 1995 in an editorial in the Journal of Clinical Oncology by two radiation oncologists, one of them shown right there, Dr. Samuel Hellman. The idea that they were sort of advancing, if you will, has also been called the spectrum theory. And to some extent, they were reacting to what were the two prevailing theories of cancer spread that had been present for the decades and near century prior to that. And first of all, there was this classic notion of the so-called Halstead spread of cancer, and that would be more or less that cancer starts at point A, goes to point B, and spreads to point C, and gets out of control at that point. And so all efforts should be directed at that point towards catching it when it is in that very beginning phase and hasn't really moved, or else you're pretty much ball game's over. The other notion that had become more popular in the 60s, 70s, and really in the 80s had been something advanced by a very well-known oncologist named Bernie Fisher, and it's a more systemic theory of cancer spread. And it is that the notion that almost from the get-go, from the moment a person has cancer, it is rightly considered a systemic disease, and for that matter, you might as well do just a little bit, or as little as you want, or as little as you can locally, but mostly concentrate on the systemic spread of disease and not waste so much time just focusing on individual spots on this in-between state. This is where the spectrum theory, or the theory of oligometastases, tries to situate itself in between those two things, because over and over we observe these cases where patients can be found to have some limited spread of cancer, treated aggressively with surgery, radiation, radiofrequency ablation, and lo and behold, in many cases, they are able to achieve an extended and very high-quality survivorship. If you look just through one of the better-known online search engines for medical literature and look at this word oligometastases or oligometastatic, you'll see that from that first coinage in the mid-1990s towards more recent years, there's been a sort of exponential growth. So, I mean, I think we're at a tipping point, if you will, of focusing in on this particular subtopic of oncology. And so I think that just speaks to the idea that this focus of this symposium is a very topical and timely subject matter. There are some other theories that you can apply if you're trying to think of why you might want to do something just locally to one spot in a person's body, even though you might be concerned about cancer cells floating around in their bloodstream. One of them would be in the general category of immune response modulation. And the general idea here is that you might want to do something, if you can, that would favorably manipulate the tumor cell's antigenicity. In other words, to trigger a very favorable immune response to that tumor spread around the body. And I'll show an example of that in the context of talking about some melanoma studies that are ongoing right now. There's another way to think about cancer, which is to say that if you could only predict where it's going to reoccur again, and by that I mean if you had an understanding of what in radiation oncology has been long called the patterns of failure. In here, the classic case, and in fact the situation on which a lot of the field of radiation oncology is based, would be an understanding of lymphomas. And in the early years of radiation oncology, it was well understood that certain lymphomas will show up in a certain lymph node and then proceed to the next one and proceed in a certain pattern of fairly predictable and orderly spread. And if we can intercept them and take action against those known sites of failure, we might be able to do a good job for the patient. And in this particular context, I'll give you an example of how we've used that sort of patterns of failure logic to attack systemic spread of lung cancer. And finally, there's another hypothesis that's been around for a while that has been called the Norton-Simon hypothesis. And it has a certain mathematical complexity to it, which the mathematicians in the room might enjoy, but I would not do it justice to give the complete underpinnings of it. But in a very simple way, it is that there is, in most situations, an orderly progression from a small amount of cancer in a person's body, then there's more cancer in that person's body, and then there's a lot of cancer in that person's body. And once it reaches a lethal burden, too much for that person's body to handle, that's where the trouble starts and the fatality occurs. And so everything that we can do to prolong, extend, prevent, delay that time when a person reaches a lethal burden of cancer in their body is a good thing. And I'll give you an example towards the end of a situation where we conceptualize what we're doing as an extension of this so-called Norton-Simon hypothesis. In some sense, there is a new oncology brewing, if you will. And by that I mean, if you look at the traditional mechanisms of treatment of cancer, for many, many years, the primary treatment has been typically the surgery or radiotherapy, occasionally some other modalities of local treatment, and the adjuvant treatment has been, for many, many years, traditional systemic cytotoxic chemotherapy. What we're entering here is a new age, if you will, at least for some cancers, where we're lucky sometimes to be able to identify a very attractive and very slick and very clever so-called targeted agent which attacks a known Achilles heel that's present in most cancer cells, typically a chemical reaction that is vital to that cancer's continued growth and progression in that patient's body. And that may become more the focus of what we're doing primarily to the patient, with these things, stereotactic radiation, selective resection, RFA, being adjuvant to that. And that's just another way of describing this sort of intellectual sea change that has been going for the last few decades and is becoming a more and more mature way to think and rethink how we approach cancer in many situations. Okay, so let's talk then about the tumor ablative forms of radiotherapy, beginning with cranial stereotactic radiosurgery. This is a technique that was invented and developed in the 1950s and early 60s by a very famous neurosurgeon named Lars Leksell. He actually, interestingly enough, when reporting his early experience of the first 800 or so cases, was mostly doing something of a functional nature. He was a neurosurgeon by trade, and he was often looking to ablate bad things in a person's brain. And in particular, the example I show in the right-hand corner is a post-mortem examination of a patient's brain, in particular the thalamus. That particular individual was treated for chronic cancer pain, and the effort that was being done there was to try to reduce and eliminate the pain center in the brain, if you will. So it wasn't a direct action upon that particular person's cancer, if you will, but certainly an effort to improve their quality of life. Now, this particular technology, although it began as a functional tool, if you will, a functional neurosurgical tool, has definitely evolved into being primarily a tumor treatment. And it's clearly now the vast majority of cases treated with stereotactic radiosurgery are patients who have limited numbers of metastatic tumors or sometimes primary tumors in the brain. Now, the movie I'm showing you is just to offer a visual of what this is, because whenever we keep using these words stereotactic and radiosurgery, we're talking about systems of treatment whereby we're generally focusing a number of different beams of radiation towards a defined focus of treatment. And so this particular, I think the elective sponsors are probably happy I'm showing this particular movie that I borrowed from a colleague. But this is illustrating one of the very nice and classic technologies, in fact, the direct offspring of the original form of technology developed by Lars Leksell. It's a device called the Gamma Knife. And what you're going to see in a moment is this idea that from a number, literally hundreds, of individual sources of radiation precisely channeled towards individual lesions within a patient's brain, there is a way to direct a high dose of radiation that converges upon individual lesions, as you'll see in a moment, individual tumors within a brain. And by virtue of the fact that it is coming from so many different angles, no one other part of the peripheral brain gets so much radiation that it is likely to be injured. And so here you see, in this particular case, that oblong-shaped lesion being treated very effectively with a number of different so-called shots or different repositionings of that patient. And so it's a very nice way to go about your business in treating brain tumors. Now, there have been thousands of clinical studies and technical papers published, and radiosurgery is now really well established as a means of eradicating small brain lesions. Both ASTRO and the Professional Society of Neurosurgeons have periodically published position statements on this topic, and I'll just show you the most recent one of the sort of official interpretations of the data such as it is. And it was a combined effort from ASTRO and the two professional societies of neurosurgeons, whereby they looked at the nearly 17,000 or so papers written to date on stereotactic radiosurgery and found the 32 best ones which characterized clinical outcomes after treatment of patients for brain metastases. And the upshot of their analysis is that it's been well documented that radiosurgery is a very good means of helping patients with good performance status and up to a few lesions at the very least, because it's easy to observe very prolonged survival with patients who are selected appropriately with a limited burden of disease in their brain and still are in good shape to tolerate this sort of treatment. There are two lingering questions that have been, I'd say, almost completely answered, but maybe still have some doubt in some people's mind about how best to incorporate radiosurgery with other forms of radiotherapy at least. And the question is, do we add anything by adding what's called whole brain radiation therapy to stereotactic radiosurgery? And the idea there is that, well, if we see 1, 2, or 3 lesions, maybe 4 lesions, we have an awareness that there's a high chance that there might be some that we just don't see. Our imaging methods are just not good enough to detect it. So should we add something of a sort of elective nature and give something of a bath of radiotherapy to the rest of the brain, if you will, some moderate dose trying to get rid of those little spots? A related question to that would be that, is there actually an upper limit for the number of lesions beyond which radiosurgery is inappropriate? I mean, do we hit a tipping point there, if you will, by too much stuff going on, too many individual lesions to go on? It's an open question and one that's been under active investigation. The most recent study to be published that speaks to the first one, which is to say whether or not it's useful to add an elective treatment to the rest of the brain, in other words, to try to get at the little bits that you can't quite see on an imaging study, even the best MRI, most recently published here. And it's not the first. It's actually the third or fourth study of this kind. But I put it up there because it's the most recent, and it was a nice study and cleanly reported in a high-profile oncology journal. In this particular setting, a patient could have had either surgical resection or radiosurgery for 1, 2, or 3 small metastatic lesions, and then either were followed carefully or, in fact, had the added treatment given to them, which would be this modest dose whole brain radiotherapy to try to get rid of the little pieces. The results are much like the other 3 or 4 studies which have done this exact same thing. And bottom line is, it doesn't actually help a patient, in this setting at least, to go after those little bitty extra pieces. And the reason that's probably the case is that nowadays, in the case where there's a good patient, a compliant patient who's going to come back for follow-up, you're very likely to be able to see the new lesions that come up and still have time to intercept them before they become an overwhelming problem for the patients. And also, although in this particular study there were no neurocognitive testings performed here, when you change from doing a pinpoint treatment to a small lesion to a much broader treatment to the entire brain, there's a price to pay, and the patient pays that price. And the patient pays the price of being frankly, a bit more tired and sometimes a bit more forgetful, at least for several months after treatment. And so there is a downside to this. Even if it's going to get you the equivalent survival, there's a negative to this that has to be weighed into consideration. This I just show you is something that speaks to that second question I just mentioned of that, is there an upper limit to the number of lesions that can be treated? Well, I can't say for sure that there is no upper limit. I can say that there's pretty good data that says that even up to 10 lesions, as long as they amount to just a fairly small total volume, is still probably okay to go after. There's a very large-scale operation going on now in Japan, a prospective multi-institutional study in which patients with up to 10 metastases will be treated with this sort of pinpoint type of treatment. The precursor to that is a very large retrospective experience of nearly 800 patients who met the criteria of patients for whom they think this is a reasonable thing to do. And that would be patients newly diagnosed, up to 10 lesions, less than 10 cc's volume of the biggest tumor, and less than 15 cc's total volume of all the cancer in the brain. And as you see on the right-hand side, what is shown there is a survival outcome for various subgroups of patients with 1 to 2, 1 to 3, 4 to 5, and up to 10 subgroups. And actually, as a matter of fact, if patients are selected according to that, you really don't lose anything, even if you go after patients with up to 10 lesions very, very aggressively. Okay, so we'll transition now from the cranial aspect of this to the extracranial translation of this, if you will. And so the generic term we now use for what amounts to the extracranial form of cranial radiosurgery is stereotactic body radiation therapy, the body word being chosen to emphasize that we are outside of the brain. It's very much a translation of what we were just showing you about cranial radiosurgery. So on the left-hand side, you can see what I'm representing in the sketch and the patient on the table. She's tightly immobilized. She's going to be having a treatment of the sort of multiple beam approach attacking an individual brain tumor, as you see there sketched out. The extracranial version of that would be to have a patient sit still, and in this particular case, maybe you're treating a liver or a lung lesion, but in principle doing something of a very similar nature, which is to say approaching it from a number of different directions so that the radiation dose all converges in the place where you want a very high and intense dose of radiation, and yet no particular place around the outside of it gets so much that you expect to cause injury in some of the nearby tissues. And that's the basic essence of translating the cranial aspect of this to the extracranial setting. Now, SBRT has a wide spectrum of applications. It's been well studied as intensified treatment to various primary cancers. The poster child indication of it, if you will, would be medically inoperable early-stage lung cancer, but it's also been well studied in liver cancer and pancreas cancer as well as prostate cancer. It also provides a means of providing good palliation for challenging sites of recurrence, and I'll show a little bit of data on this for the spinal condition. But here we're going to try to focus a little bit more, since we're thinking about oligometastatic disease, in its role as an adjuvant systemic cytoreductive therapy, if you will, quote-unquote radical treatment, aggressive treatment for isolated liver and lung and spine and other oligometastatic settings. If you look at the academic activity and radiation oncologist adoption of SBRT, there's a rather close parallel. If you look at the number of papers published in the major radiation oncology journal over the past 5 or 6 years, there's a clear escalation. Once again, this sort of exponential drift upwards, if you will, that suggests that we've hit some sort of tipping point. And I guess here you could say that the tipping point might be the widespread implementation of it. And so what you see in the background is from a paper published in Cancer this year from the UCSD group, in which there was simply a survey of utilization of this technology. And by 2010, as you can see, according to this x-axis, the y-axis, which is the percent of physicians now implementing it, you've crossed the threshold of more than half and into the 2/3, and I'm sure it'll approach near 100% saturation level of radiation oncologists adapting this and beginning to use it in their routine clinical practice. So it's not even so much a truly investigational thing. It's become a very widely adapted form of approaching. If you look at the individual places within the body that folks have used this up to date, it's not surprising that lung and spine and liver lesions are perhaps the most commonly treated sites. I predict over the next few years that prostate cancer will probably enlarge to a great extent. And once again, this is the percentage of physicians who do SBRT who treat these individual sites. And I just predict prostate cancer will be a boom field for this, only because there is so much prostate cancer, and there are reasons to think that it might be a very good means of working on that, a very efficient way to go about your business here. Now, there are some critical differences when you're doing something outside the brain versus when you're doing something in the brain. Notably, things outside the brain tend to move a lot more. The patient, of course, needs to be safely immobilized and comfortably immobilized on the table because sometimes these treatments can last a bit longer than a conventional treatment. You need to see what you're aiming at, and you need to verify by means of some form of image guidance, either a near real-time CT scan or some other form of secure imaging to make sure that you're targeting what you want to target. And then, of course, you need to adapt to the patient's respiratory motion, and there's a variety of different ways to overcome this. I just show the cine cartoon on the right of MRI showing liver and diaphragmatic motion to just illustrate that there is this situation. But fortunately, there's a number of tricks of the trade that are able to work around these particular things. Now, the industry is now fully mature in the sense that all the major vendors of radiation oncology equipment have put together composite systems that are particularly well suited to performing this sort of highly focused, image-guided, intensive radiation treatment. The one up in the right-hand corner is the one that's present here. It's from the Elekta company, once again. But all the other major manufacturers have competitive products that all do a very good job of facilitating this type of treatment. Now, what is so attractive about SBRT? I mean, what is the core, essential romance about this that maybe has contributed a lot to folks in the field becoming a bit more excited about it? Well, of course, it's fast and it's potent and it's non-invasive, and that's all well and good, and it's very well tolerated across the board. But the interesting thing is that maybe we're doing something that's actually biologically different from what we have generally done in the past, and I'll try to illustrate what I'm talking about in that regard. So, the notion here is that in addition to the ways that we've traditionally understood radiation to work on cancer cells, which is to say screwing up the DNA and making the cell, rendering the cell incapable of competent, continued replication and growth, perhaps we're also working at it in this context through a different mechanism. And I'll just share with you some observations from this is from MSKCC. That's that other Kettering Cancer Center. I don't know if you've heard of it. It's in New York. It's a smaller place, but it's somewhere east of here. They've been active in this context and at the Memorial Sloan Kettering. And this is one of their many reports, and it illustrates one of their theories on this. And it goes something like this. If you see in the upper left-hand corner, this is an illustration of a pre-treatment lesion, and I'm outlining it right here. It is a metastatic colorectal cancer that's what you see here is a cross-section of this patient. This is a vertebral body. This is the spinal cord. It's very close to the spinal cord. Treacherous territory. You've got to be very careful about radiation around this structure, the spinal cord in particular. Very important structure. We never want to cause anybody severe neurologic problems. But it can be done. It can be treated aggressively. And what their point is by showing their 3-month later example is that what this appears to be is a situation where the tumor has imploded to some extent. It has become devascularized. It is largely necrotic. And the idea is that very likely what we're seeing here is a breakdown and a very effective breakdown of the blood supply. In other words, an anti-angiogenic effect. Now, this is just their clinical outcomes that shows that with their treatment in this context, they've been able to achieve a very durable high rates of local control with lesions like this. In particular, when they're very aggressive, there's a dose response. Single fractions on the order of 18 to 24 gray achieve a very high rate of sustained local control. But the reason to go back to it, the reason they think that this might have a very direct connection with an anti-angiogenic or an anti-blood vessel phenomenon is based on a lot of their preclinical work. And I show you one of the highlights of one of their major papers from that line of investigation right here. What you see on the right-hand corner is a graph that's typical in a lot of preclinical cancer papers, which is called a tumor growth delay curve. And so you have on the x-axis here days after tumor implantation and simply the tumor volume. And so what you have here is the growth of tumor after radiotherapy in animals who are apoptosis incompetent. Specifically, they're unable to undergo the programmed cell death that radiation typically achieves among its several mechanisms of killing cancer cells, whereas apoptosis competent cells, mice who are engineered to have this particular chemical/molecular mechanism of cell death, have a much longer growth delay. And as they drilled down to figure out can we get a little more detail about this, it seemed to be the case that in particular what was happening was a very strong effect on blood vessel cells in particular, so-called endothelial cells. And so what you see right down here is a dose on the x-axis and the percentage of apoptotic cells. And so in the animals that were able to do this particular molecular mechanism of cell death there was a much stronger effect on blood cells and blood vessel cells in particular. And that's one of the key papers and other supporting evidence that has led a lot of people to buy into this notion that we're doing something different because not only are we hitting DNA, but we're starting to hit some other Achilles heels, if you will, to use that metaphor once again, of cancer, namely in this case, blood vessels. We have a couple of examples of preclinical data out there in the literature. This is just from our colleagues in Colorado State, a special assay in animals showing a higher rate of this type of reaction in blood vessel cells. We published a tidbit of data on this in a paper in Clinical Cancer Research using an assay before and after treatment, and again, indirect but supportive evidence of this concept. All right, so let's then develop this idea a little bit of SBRT for lung, spine, and liver metastases just a little bit more. We'll look specifically at lung and liver metastases, or at least 4 series. As a matter of fact, there are 2 more series, I should update this slide, out in the literature, looking at SBRT, this high-dose focused, very short course radiation therapy for lung metastases, and also 8 or 9 series in the literature, including a pooled analysis from several institutions that I'll develop a little bit, on using it for liver metastases. I'll just show the slides from our own study at University of Colorado. It was a situation where we did a dose escalation in patients with 1 to 3 lung metastases. They all had solid tumors. The maximum total diameter had to be less than 7 centimeters. They had to have decent pulmonary function, and no systemic therapy within 14 days before or after SBRT. We were able to safely escalate the dose up to a level of 20 gray per fraction times 3 fractions, and we were able to achieve a very nice sustained 90% local control rate for those lesions, so that was nice. The typical observation of a patient after this treatment would be shown right here. This is a patient with a metastatic renal cell cancer before treatment. Superimposed upon that particular slide is the distribution of radiation that was given to this patient, and what you can see there is that in this red, there's the focus, intense, and hot spot of dose, a very high dose concentrated right here. And as you go outwards from this, sort of like ripples in a pond, there are indicators of less and less radiation deposited in the lungs as you get further and further away from the targeted lesion. At 1 and 2 years after treatment, you typically see a little bit of scar tissue, and then it fades out into a sort of permanent blemish, if you will. There's always a little bit of a footprint left behind, but that's maybe not so unexpected. And generally what's used in the context, if you ever need to figure out whether, the residual scar you see is just scar tissue or is active tumor, we'll often use a PET scan if we need to sort through what's up with that. But again, we were able, generally speaking, to get a very high rate of control of tumors using this technology. We did a parallel investigation in liver metastases, and I'll go briefly through that. We were able to escalate the dose once again from a starting level to a level of what amounts to a very aggressive form of treatment, 60 gray in 3 fractions. Again, that's the sort of treatment that was usually given in about 30 or so fractions in most conventional regimens. So we've taken a total dose that's been given in 30 treatments often and consolidated that down to 3 individual treatments. And by doing so, it's a much harder hit and a real sledgehammer type effect on most cancers. And we had a couple of different ways of looking at how to be careful about the liver volume that was treated, and had some specifications on how to do that. Once again, published in JCO a couple years ago, 1 to 3 liver lesions, a couple of constraints on good liver function, and the amount of normal liver that had to be spared, and we were able to see a pretty good local control. We did see a little bit of a volume difference. It is easier to get rid of smaller lesions than it is to get rid of larger lesions. That's perhaps no surprise, but in any case, on balance, about a 90% or so sustained local control out to 18 to 24 months or so. Now, I mentioned that we have recently pooled our data with some other folks, and that's going to give you some power of statistics, if you will. So we put together our experience with the Stanford group and the Princess Margaret group, and I'll emphasize that this is specifically on patients with colorectal metastases, a very heavily pretreated population, I might add. We're often going after people, especially in the early days of this, before we had any track record of this. I mean, it was certainly the case that patients would have exhausted a number of other options before they got around to us and were given this sort of treatment. Nowadays, we maybe catch people, generally speaking, a little bit earlier in the process of things. But be that as it may, I point out that this combined group of about 65 or so patients with 100 individual lesions were heavily pretreated. 70% of them had at least one prior systemic regimen, in addition to a number of other local treatments. And what we saw is that a multivariate analysis for overall survival, not surprisingly, that the presence of extrahepatic active cancer outside the liver was a bad thing. But also, interestingly enough, sustained local control from the treatment was associated with longer survival, meaning that even in this heavily pretreated population, we felt that we were getting a favorable impact on their survivorship by eliminating this particularly nasty site of disease progression. Liver disease, and as it progresses, can be a very fatal event. And so if we were able to contain that, and we were able to do that in a number of these patients, even after heavy pretreatment, we think we had a favorable impact on their overall survivorship. Now, shifting gears slightly, we'll cover just a little bit about spine, SBRT, and radiosurgery. And I summarized for you here the 5 or so major institutions who have contributed to the literature. I would say the Henry Ford Group and Detroit have been very active, probably the initial leaders of this, closely followed by MD Anderson and that other Kettering place again, and the group in Pittsburgh and Stanford, all of whom have used some slightly different variations and slight stylistic variations, but bottom line, all been able to do a very aggressive form of treatment to spinal and paraspinous lesions and get a good outcome. I'll show you again the Memorial Sloan Kettering group reported a couple of times, once again showing an overall 90% or so local control rate, very comparable to what's been achieved and reported from Pittsburgh and MD Anderson. I highlight one particular paper of recent note from the MD Anderson group, which is a spine SBRT for renal cell cancer in particular. The reason I think this paper is particularly nice is that it includes not only pure local control endpoints, but also includes some quality of life endpoints. And so what you see on the left-hand graph is that for the 48 patients who were treated with a total of 55 lesions that were either in the spinal vertebral column or just next to it, where the spinal cord is extremely close to it, what you could see is that over time after treatment, up to about 2/3 or so of these patients were rendered entirely pain-free, which is a good thing. And what you see in this right-hand column over time, and this is weeks on the x-axis, these are a variety of annoying symptom scales, if you will. These are all quality of life indices. It is good to have them go down. What you see here are representations of general activity, mood, ability to do normal work, etc. So as these things go down, that's a good thing for the patient. You can see that it's been a nice effect achieved and a very important one, not only in terms of longevity, but also in terms of quality of life for the patients who were treated in this particular study. There's an RTOG study, a radiation therapy oncology group, one of the NCI-sponsored groups, ongoing right now to look a little bit more at this. And in the interest of time, I'm going to move forward about that. It's studying this particular notion in a bit more detail. Now let's shift gears and get into this idea of saying, well, I mentioned that one of the other theories or justifications or possible hypotheses, if you will, of thinking you might be doing something good with a high dose of radiation to an isolated lesion in someone's body is that maybe you're doing something good to the immune system. And I'll give this example of melanoma and try to shake it out right here. This is very interesting preclinical data from the New York University group, and it goes something like this. It happens to be a mouse model of an implanted breast cancer cell. There were 2 tumors put in this particular animal's body, one right here and one right here. Only one of them was irradiated. And what you see relative to control is that, once again, this is a tumor growth delay experiment. There is the unbridled growth of the control setting where the animal got no radiation. And then there's a very favorable effect in terms of delaying the tumor growth when you give radiation with or without a certain agent that has a particular immunologic function. What's fascinating is also that you can see an effect on the other side. In the tumor that was not irradiated, there's an interesting synergistic so-called abscopal effect, meaning an effect that happens away from the area you're actually treating. It's a very surprising, very interesting effect, whereby there is an appropriate induction of antigens that trigger the immune system so that that animal's body is then attacking the other tumor. And it is also an effect that is augmented by a very specific agent that blocks a very specific function in lymphocytes that expands and magnifies their immune system. Now, hold on to this notion of using this particular type of medication, because that is the type of medication that's been a recent breakthrough in the treatment of melanoma from a systemic perspective. There's an agent called ipilimumab, which has a very specific effect on lymphocytes in a patient's body, which has the very good effect of killing melanoma cells. And it's represented here, the pivotal study that's represented here is that using this agent, which admittedly has the weirdest name, I don't know how they come up with Yervoy. I mean, what's that supposed to be? I don't know. It's some kind of, the generic is an easier one for me to even say, ipilimumab. Even though it's a tongue twister, I still can't take this medication named Yervoy seriously. I mean, is that some kind of robot from a 1960s science fiction movie or something? I don't get that. Somebody said, when I asked him about that, I was joking with somebody else about that, and he said, yeah, I was in the room when they came out with that, and I immediately nominated, maybe we should just call it Nebish or something like that, because I don't know. But anyway, for some reason, these people think that Yervoy is a good name for their drug. Fine, let them have it. It's a good drug, I'll tell you that, because it has a very favorable and very significant improvement in patient survival. And so as you see here, the two arms of the study who received Yervoy with or without some vaccine, sort of a placebo vaccine, did much better than the group who did a vaccine treatment alone. Now, we've also looked at our own institutional experience of using SBRT for isolated lesions of melanoma and renal cell. We did combine them into two because they've traditionally been understood to be somewhat similar biologically. They're tough to get rid of with radiation. You've got to be pretty aggressive about that. So be that as it may, we put together our own experience and observed that, yeah, if you're aggressive enough with the radiation treatment, and this particular metric is a composite dose metric, but if you're aggressive enough with the amount of radiation you give to individual sites of melanoma or renal cell cancer, you can have a pretty good chance of getting rid of them, and keeping them away for a very long time. So that's a good thing. So as you see, where this may be going is that, yes, we've recently got together with the folks from Nevada and a couple of other institutions, and we're going to put these two pieces together in patients. We're going to do a very simple study and use that particular agent I just showed you. It's very good for melanoma, and SBRT, both of which have independent activity against this disease, and putting them together might have some extra synergy because of that very exotic, still incompletely understood, but very interesting immune reaction whereby the radiation seems to trigger a favorable enhancement or awakening of the immune system, and this drug certainly does that same thing also. All right, give you another example. This is giving you an example of what I termed already the patterns of failure logic, and this is the situation where you might be able to predict what's going to happen if a patient gets a certain treatment, and what's the problem going to be. Even if it gets systemic treatment, where is it coming back, and what are you going to have the most chance to intervene favorably. So this is a study we did with that in mind. And so basically we put a couple things together and it goes something like this. There's an agent known as Erlotinib, which has a specific molecular mechanism for lung cancer patients. It inhibits a growth factor on the cells of some of these cancer cells called EGFR. It's been shown to be a good thing for selected patients with lung cancer as a second-line treatment. Relative to placebo, it extended overall survival a bit. But as you can see, with overall survival in the range of 6 or 7 months and progression-free survival in the range of 2.2 months, yeah, nice, some progress, but still there's work to be done. This certainly can be improved upon, or so we hope that this could possibly be improved upon, because I don't think anyone's quite satisfied with this as the overall survivorship outcome. Well, another thing we've done in our own group had been to look at patterns of failure in metastatic non-small cell lung cancer, and this is a very intuitive and very self-evident thing. We went through the exercise of proving it, but it goes something like this. We looked at the 300 or so patients who had had first-line therapy with standard chemotherapy for lung cancer that had been metastatic. Not surprisingly, the vast majority of them who had some response progressed in the areas that they were known to have cancer in at the time they got the chemotherapy. I'll say that again. It's so obvious, I'll just say it again because you didn't miss it. It's just that obvious. It's no surprise. Give somebody chemotherapy, it is likely that they are going to regrow in the sites that have a lot of cancer in them. That's not meant to be a tricky thing. We went through the exercise of proving it. But what you can see is where we're going with this is that, well, maybe we should put 2 and 2 together. So we have this nice systemic therapy, nice new jazzy systemic therapy. If we combine that perhaps with this nice targeted thing and pick out and go after the sites we knew to be involved, maybe we could have some sort of favorable effect because we know that's where they're going to recur. We know that the pattern of failure is going to be growth in those same spots. And so that's how this particular study was structured very simply. You give the drug, you give SBRT. Our selection criteria was up to 6 lesions, so I'm not saying that that's an absolute line in the sand. You can't go above or beyond that, but we did have to put some sort of parameters around it. So I will say an answer indirectly to the question that was posed earlier. In our studies, we have put 6 as an upper limit of individual sites of disease. But in any case, we treated them, and this is what we observed. So first of all, what we did was see a flip-flop in the sense that we saw a different pattern of failure. Now we see patients who are more likely failing somewhere else than the place where they started, because we've tried to take care of those spots. And in terms of overall survival, it's a very encouraging result. I mean, it's only a small study, about 25 or so patients, but still, an overall survival of about 21. So it's about 3 times what was reported, at least in the pivotal study for Erlotinib, to be the overall survivorship. So we find this to be a very encouraging thing, and we're just about wrapping up this study. I need to get it written up to sort of get it out there. Now, I'll finish up with this one more example of this thing that I use this ridiculous term for. I'll call it Darwinian oncology, and what's up with that. All right, fine. So, there is, I think, one of the best drugs out there nowadays, which is called an even newer agent. It also ends in the 2 letters IB, so it rhymes with Erlotinib. It's called Crizotinib. It is a very good medicine for the few people who are likely to get benefit. Now, in the modern context, and this topic will probably be developed a little bit in the 4th talk today, but in the modern oncology context, it is often possible to identify cancers in a way that can predict responsiveness to different agents. So in particular, it's about 5% of lung cancers who have a particular genetic feature which will respond quite well to this particular agent. And I can say that for someone who's been in the field 10, 20 years now and has seen a lot of cancer drugs come and go, for the 5% of lung cancer patients who see this, it's the most remarkable drug I've ever seen. Radiation oncologists and perhaps surgeons are trained perhaps to be sometimes skeptical of systemic therapies. They haven't necessarily had the full track record, but this agent is good. I'll just tell you that. Well, I'll show you how we've begun to think about this. This is a report from the New England Journal article from last year showing a very good progression-free survival and what amounts to a very good before and after response in this agent. So here's where the Darwinian oncology comes in. Now, I wish what I was showing you would be something that proved that radiation oncology has now evolved. And what I'm talking about is the evolution of the radiation oncologist itself. I'm not really talking about that because I'm not sure we're really any smarter than our ancestors. But be that as it may, the Darwinian thing comes from a slightly different direction. It goes something like this. Let's consider one example case. This is a lady who was diagnosed a few years ago with a lung cancer. She got some initial chemotherapy. She got a left pneumonectomy. Did okay for a while, but about 7 or 8 months later had a mediastinal recurrence. Okay, fine. That's not too far away from where it started. We can still be pretty aggressive. She's in good shape. She got that irradiated. Okay, so she's doing fine, so that's all good. Unfortunately, she then had disease explosion about 6 or so months later. And what she had was, and this is a representation of a PET scan, all this white stuff right here is bad. That's cancer. That's her heart. That's okay. That's her bladder. That's okay. But this stuff is bad. That's a lot of cancer. That's a tremendous amount of cancer in this person's body. She was lucky enough to be among the 5% of cancer patients who are going to be responsive to this particular agent. And so here's what happened. She gets the agent, and within 2 months, she had a fantastic response. This is not actually that unusual for this particular thing, but she had a very, 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 very good response. And what you can see from a before and after thing is there's a lot less of this white stuff. That's the cancer. It's not there so much anymore. A little bit of bowel activity, that's normal. Okay, fine. However, here's the problem. This is why the cancer will always still win. And it's because the odds are about 40 billion to 1 in favor of the cancer. And what I mean by that is that we've just found that this particular cancer has a particular weakness. It has a nice Achilles heel. We've targeted it, we got a hold of it, and we tricked it. And that's a good thing, and we can trick it for a while. But there are 40 billion cancer cells in that woman's body, maybe more. I'm just guessing that, but it's orders of magnitude higher than millions. And we're only trying to block one particular pathway. By chance, you can depend on it, bet your house on it, that somehow, some way, there's going to be at least 1, 2, 3, or 100 cancer cells who will evolve by Darwinian natural selection to manifest a resistance to that particular agent. And that always happens. Bank on it. It's guaranteed to happen eventually. However, it doesn't mean that you have to give up on this particular patient. So this is how this particular story fills out. So this is the point at which she's had this terrific response to this particular agent. She's doing pretty well. Lo and behold, a number of months later, she starts to have the first evidence of a resistant clone. It comes up in her right adrenal gland. Well, yeah, guess what we did? We went after this thing. We treated it very aggressively. We used an ablative form of radiotherapy because we said, look, she's doing great otherwise. She's tolerating this drug otherwise. That's just one little spot. Let's just take that piece off the table. Fine. That's good. A few months later, we get a good response. However, unfortunately, not entirely unpredictably, she has another spot. Okay, that's what we do. We do this. We repeat this exercise for that spot and even a third spot. And so what amounts to what it amounts to is that by being selectively aggressive in the places where we saw a resistant tumor clonogen emerge, because again, the odds are 40 billion to 1 against that not happening, we intervened to the point that we could, and we did reach at some point a place where the woman that was too much disease or was in locations that we couldn't quite be that aggressive on, and eventually she did progress. But this lady got 9+ months of extension of access to this particular agent, which was still doing a very good job for the other 39,999,000,000 blah, blah, blah cancer cells that were still well controlled by this particular agent. And so this is a new metric, if you will. It's a new way of thinking, I think, about how we have an interaction between a systemic therapy and a local therapy. And I show it right here. This is some of the unpublished data that I left out here because we're in the process of sort of trying to write this thing up. But what I'm showing you here is that for patients who were observed to have a first failure, who then had a second local intervention, and in the vast majority of cases that was radiation. However, there are a few patients who got surgery and one or two other interventional procedures. We can talk about how they're selected for one or the other in the question session, but bottom line, think of it as having patients who had an aggressive local therapy for an isolated systemic failure on this particular agent. We were able to extend by upwards of a year their ability to access and still gain benefit from this particular drug before we threw in the towel, and eventually, for some reason or other, might still have to yield to the cancer. But I think this is a very real thing and a very good thing, and I think it's a new way that we have to sometimes think about how we engage different modalities of treatment and how we conceptualize that whole person and the different things that we might have to bring to bear on this particular battle against cancer. So at that point, I thank you for your attention, and I'll stop there and be happy to take questions.
Any questions?
When you give the stereotactic radiation therapy, a lot of these patients are on systemic therapy before or afterwards. How long of a period do you hold the systemic therapy before and after?
So the question was, how long do we withhold the systemic therapy if we are somehow intercalating focused local treatment with a systemic therapy in the background? And I'll give you 3 answers for that because we've done it in 3 different ways. So on the Erlotinib study I showed you, we just kept going. In fact, we just gave it concurrently. I mean, there's a fair amount of literature that would support that you can give radiation with various ways of inhibiting EGFR targeted drugs in particular. On the Crizotinib study, we don't give it on that same day. So we do a 1-day off thing for the days of actual treatment, but continue it on the other days. However, in all the other situations, all the other studies we've done, we've usually done about a 2-week or so washout to avoid traditional systemic chemotherapy. Could you do it closer? You probably could, but that's been our usual window. We're often catching people when they're about looking for a break anyway, so we'll often work it in that way. But that's been how we've done it. I mean, I don't know if that's the best way, but that's how we approach it. And I should say we have a couple other studies. I mean, that's the extracranial context, just to be complete. We've had a couple of other studies where we give targeted agents sometimes for brain tumors, specifically recurrent primary brain tumors, and we've continued the agent along the way. We've had a study that was with a dual EGFR and VEGF inhibitor, and then we went continuously with that. That's a little bit of a different question, but